Foundations of Maternal, Newborn, and Women's Health Nursing, 7th edition, by Murray McKinney, Holub, and Jones. Chapter 8, Nutrition for Childbearing. At no other point in a woman's life is nutrition as important as it is during pregnancy and lactation. At this time, she must nourish not only herself, but also her baby. Nutrition may affect the size of the fetus and determine whether it has adequate stores of some nutrients after birth. If the woman fails to consume sufficient nutrients during pregnancy, her own stores of some nutrients may be depleted to meet the needs of the fetus, who also may be deprived of essential nutrients. Nurses have ongoing contact with pregnant women and can provide education about nutrition on a continuing basis. This is especially important because many women do not understand the nutritional needs of pregnancy. Nurses are often able to offer nutrition counseling before conception to women who are considering becoming pregnant. Such counseling increases the chances that a woman will be nutritionally healthy at the time of conception and will continue to practice good nutrition throughout pregnancy. It also may increase the level of nutrition a woman provides for her entire family. Therefore, nutritional education is an essential part of nursing care. Weight gain during pregnancy. Weight gain during pregnancy is an important determinant of fetal growth. Insufficient weight gain during pregnancy has been associated with low birth weight, less than 2,500 grams or 5.5 pounds, small for gestational age, SGA infants, preterm birth, and failure to initiate breastfeeding. Low weight gain in the second trimester is especially associated with poor infant birth weight, even if overall gain is within the recommended range. Lower caloric intake and decreased intake of important nutrients are present when poor maternal weight gain occurs. Excessive weight gain is also a problem. It is associated with gestational hypertension, preeclampsia, gestational diabetes, prolonged labor, cesarean birth, macrosomia, stillbirth, and congenital anomalies, including neural tube defects. Approximately 20% of women gain more than 18 kilograms, 40 pounds, during pregnancy. The nutrient intake is even more important than the weight gain itself. Weight gain from a diet lacking in essential nutrients is not as beneficial as weight gain from a balanced diet. It could be inadequate in nutrients such as protein, iron, or folic acid, which could cause anemia, neural tube defects, or inadequate fetal nutrient stores. Recommendations for total weight gain. Recommendations for weight gain during pregnancy have changed considerably over the years. In the late 19th century, rickets, a disease of the bones resulting from deficiencies of calcium and vitamin D, caused some women to have small, distorted pelvises. Restrictive weight gain kept the fetus small and facilitated delivery. Later, weight gain was limited because of the inaccurate understanding that large gains caused preeclampsia. Weight gain recommendations are based on the woman's pre-pregnancy body mass index, BMI. BMI is calculated by dividing the weight in kilograms by the height in meters squared. Another method is to divide the weight in pounds by the height in inches squared and multiply the result by 703. For example, if a woman weighs 56 kilograms, 124 pounds, before pregnancy and is 163 centimeters, 64 inches, tall, her BMI is 21, which shows normal weight for her height. A calculator to measure BMI is available at blah-blah-blah.com. Recommended gains vary according to the woman's BMI before pregnancy, table 8.1. The recommended weight gain during pregnancy is 11.5 to 16 kilograms, 25 to 35 pounds, for women who begin pregnancy at normal BMI. The range allows for individual differences because no precise weight gain is appropriate for every woman. It provides a target and allows for variations in individual needs. Low pre-pregnancy weight is associated with preterm labor, SGA, and increased perinatal mortality. Women who are underweight should gain more to meet the needs of pregnancy as well as their own need to gain weight. They should gain 12.5 to 18 kilograms, 28 to 40 pounds. Obesity is an increasing problem. When obese women become pregnant, they are at high risk for spontaneous abortion, gestational diabetes, gestational hypertension, preeclampsia, prolonged labor, cesarean birth, congenital anomalies, macrosomia, postpartum hemorrhage, wound complications, and thromboembolic disorders, and other postpartum complications. Their children have an increased risk for childhood obesity. Overweight and obese women should be advised to lose weight before conception to achieve the best pregnancy outcomes. The current recommended gain for overweight women is 7 to 11.5 kilograms, 15 to 25 pounds. Provide sufficient nutrients for the fetus. The weight gain for obese women is 5 to 9 kilograms, 11 to 20 pounds. Lower weight gain or weight loss for obese women during pregnancy is not recommended at this time because evidence of the effect on neurologic development of the infant is insufficient. More research is needed in this area. Inadequate gain may cause catabolism of fat stores producing ketones, which may lead to preterm labor. In the past, it was recommended that shorter women should gain only the lowest amount of the recommended range. However, evidence to support these guidelines has not been identified. These women should gain according to recommendations for their BMI. Adolescents should gain weight according to their pre-pregnancy BMI using adult rather than pediatric BMI categories. Using adult BMI categories may place adolescents in a lighter group who are advised to gain more weight, but additional weight gain in younger adolescents often improves birth outcomes. Another consideration is the woman who is pregnant with more than one fetus. Infants of a multi-fetal pregnancy are often born before term and tend to weigh less than those born of single pregnancies. A greater weight gain in the mother may help prevent low birth weight. The recommended gain for women of normal pre-pregnancy weight who are carrying twins is 17 to 25 kilograms, 37 to 54 pounds. Pattern of weight gain. The pattern of weight gain is as important as the total increase in weight. Early and adequate prenatal care allows assessment of weight gain on a regular basis throughout pregnancy. The general recommendation is approximately 0.5 to 2 kilograms, 1.1 to 4.4 pounds, during the first trimester, when the mother may be nauseated and the fetus needs few nutrients for growth. During the rest of the pregnancy, the weekly expected weight gain ranges and means for various pre-pregnancy weights are shown in Table 8.1. Maternal and fetal weight distribution. Women often wonder why they should gain so much weight when the fetus weighs only 3.2 to 3.6 kilograms, 7 to 8 pounds. The nurse should explain the distribution of weight to help them understand this need. Figure 8.1. Factors that influence weight gain. The nurse can positively influence the expectant mother's weight gain by teaching her the importance of her diet for fetal growth. Discussion of the effects of maternal intake on fetal growth and storage of nutrients often motivates women to improve their nutrition. Knowledge of factors that may negatively influence nutrient intake and weight gain helps the nurse devise plans for improving nutrition. Nutritional requirements. Nutrient needs increase during pregnancy to meet the demands of the mother and fetus. The amount of increase for each nutrient varies. In most cases, the increases are not large and are relatively easy to obtain through the diet. Dietary reference intakes. In the United States, dietary reference intakes, DRIs, are used to estimate nutrient needs. DRIs include the following four categories. Recommended dietary allowance, RDA, the amount of a nutrient sufficient to meet the needs of almost all 97 to 98% of healthy people in an age group. The actual needs of individuals, particularly for calories and protein, may vary according to body size, previous nutritional status, and usual activity level. Adequate intake, AI, the nutrient intake assumed to be adequate when an RDA cannot be determined. Tolerable upper intake level, UL, the highest amount of a nutrient that can be taken by most people without probable adverse health effects. Estimated average requirement, EAR, the amount of a nutrient estimated to meet the needs of half the healthy people in an age group. Tables of recommendations are based on a reference individual, a hypothetical person of medium size. These tables are used to calculate nutrient needs based on age, gender, and size. Recommendations for energy, carbohydrate, and protein intakes are shown in Table 8.2. Recommendations for vitamin and mineral intake and food sources are shown in Table 8.3. Energy. The energy provided by foods for body processes is calculated in kilocalories. Kilocalories, commonly called calories, the term used in this book, refers to a unit of heat and is used to show the energy value in foods. Calories are obtained from carbohydrates and proteins, which provide 4 calories in each gram, and fats, which provide 9 calories in each gram. Carbohydrates. Carbohydrates may be simple or complex. The most common simple carbohydrate is sucrose, table sugar, which is a source of energy but provides no other nutrients. Fruits and vegetables contain simple sugars along with other nutrients. Complex carbs are present in starches such as cereal, pasta, and potatoes. They supply vitamins, minerals, and fiber. They should be the major source of carbohydrates in the diet because of their value in providing other nutrients. Another type of carbohydrate is fiber, the non-digestible product of plant foods and an important source of bulk in the diet. Fiber absorbs water and stimulates peristalsis, causing food to pass more quickly through the intestines. Fiber helps prevent constipation and also slows gastric emptying, causing a sensation of fullness. A lot of charts and tables the next 3 pages. Fats. Fats provide energy and fat-soluble vitamins. When decreasing calories is necessary, a reduction, but not elimination, of carbohydrates and fats is important. If carbohydrate and fat intake provide insufficient calories, the body uses protein to meet energy needs. This use decreases the amount of protein available for building and repairing tissue. Women often restrict fat to prevent weight gain. However, essential fatty acids such as alpha-linoleic acid and linoleic acid help in fetal neurologic and visual development. Docosahexaenoic acid, DHA, is also important for fetal, visual, and cognitive development. These fatty acids are found in canola, soybean, and walnut oils, as well as some seafood such as bass or salmon. Calories. Approximately 75,000 additional calories are needed during pregnancy. These extra calories furnish energy for production and maintenance of the fetus, placenta, added maternal tissues, and increased basal metabolic rate. Most pregnant women need a daily caloric intake of 2,200 to 2,900 calories, depending on their age, activity level, and pre-pregnancy BMI. During the first trimester of pregnancy, no added calories are needed. However, the daily caloric intake for pregnant women should increase by 340 calories during the second trimester and 452 calories during the third trimester. This increase can be achieved relatively easily with a variety of foods and only a small increase in food. Table 8.4. Nutrient density. The quantity and quality of the various nutrients in each 100 calories of food is the nutrient density. Foods of high nutrient density have large amounts of quality nutrients per serving. During pregnancy, the increased need for most nutrients may not be met unless calories are selected carefully. The term empty calories refers to foods high in calories but low in other nutrients. Many snack foods contain excessive calories and low nutrient density and are high in fat and sodium. Increased calories should be spent on foods that provide the nutrients needed in increased amounts during pregnancy. Women often use sugar substitutes to reduce their caloric intake. Saccharin, sweet and low, sucralose, Splenda, aspartame, equal or NutraSweet, and steviol glycosides from stevia leaves, stevia, are considered safe for use in moderation. Use of aspartame by women with phenylketonuria can result in fetal brain damage because these women lack the enzyme to metabolize aspartame. Protein. Protein is necessary for metabolism, tissue synthesis, and tissue repair. The daily protein from recommended dietary allowances, RDA, is 46 grams for females, depending on age and size. A protein intake of approximately 71 grams each day is recommended during the second half of pregnancy because of the expansion of blood volume and growth of maternal and fetal tissues. This is an increase of 25 grams of protein daily. Protein is generally abundant in diets in most industrialized nations. Diets low in caloric intake also may be low in protein, however. If calories are low and protein is used to provide energy, fetal growth may be impaired. The nurse should teach women at risk for poor protein diets how to determine intake and increase food sources of protein. When a woman needs to increase intake, she could eat more protein-rich foods rather than use high-protein powders or drinks. Protein substitutes increase protein intake, but do not have the other nutrients provided by foods. Vitamins. Although most people do not eat as much of every vitamin and mineral each day as recommended, true deficiency states for most nutrients are uncommon in North America. Fat-soluble vitamins. Fat-soluble vitamins A, D, E, and K are stored in the liver. Deficiency states are not as likely to occur, but excessive intake of these vitamins can be toxic. For example, too much vitamin A can cause fetal defects. The nurse should ask about vitamins and medications taken by pregnant women and counsel them about the dangers of excess vitamins. Table 8.3. Water-soluble vitamins. Water-soluble vitamins B6, B12, and C, folic acid, thiamine, riboflavin, and niacin are not stored in the body as easily as fat-soluble vitamins. Therefore, they should be included in the daily diet. Because excess amounts are excreted in urine, the chances of toxicity from excessive intake are lower, but toxicity can occur with megadoses. Water-soluble vitamins are easily transferred from food to water during cooking. Foods should be steamed, microwaved, or prepared in only small amounts of water. The remaining water can be used in other dishes, such as soups. Folic acid. Folic acid, also called folate, can decrease the occurrence of neural tube defects, such as spina bifida and anencephaly in newborns. It also may prevent cleft lip, cleft palate, and some heart defects. Adequate intake of folic acid is especially important before conception and during the first trimester because the neural tube closes before many women realize they are pregnant. Because approximately half of pregnancies are unplanned, all women of childbearing age should consume at least 400 micrograms, 0.4 milligram, of folic acid every day. Once pregnancy occurs, daily intake of 600 micrograms, 0.6 milligrams, of folic acid is recommended. Although the CDC recommends a daily folic acid intake of 400 micrograms for women capable of childbearing, the U.S. Preventative Services Task Force recommends 400 to 800 micrograms each day. The dose should be taken for at least 1 month before conception and for 2 to 3 months after conception. No change has been made in the USPSTF's recommendation of 600 micrograms folic acid daily for the rest of pregnancy. For women who have previously had a child with a neural tube defect, the recommended dose is 4 milligrams, that's 4,000 micrograms daily, during the months before conception. Women often do not realize the importance of folic acid in their diet before pregnancy begins, and many do not meet the recommended level in spite of a national campaign to make the public aware of this problem. Inadequate intake of folic acid is the most prevalent vitamin deficiency during pregnancy. 1/3 of births occur in women ages 18 to 24 years, but women in this group have lower intake of supplements containing folic acid than older women. More education is necessary to increase folic acid use in women of childbearing age. Fortunately, since food fortification with folic acid was begun, folic acid deficiency has decreased. A Healthy People 2020 goal is for women of childbearing potential to take in at least 400 micrograms of folic acid each day. To help achieve adequate intake in the United States and Canada, folic acid is added to breads, cereals, and other products containing enriched flour. Minerals. Although most minerals are supplied in sufficient amounts in normal diets, the intake of iron and calcium may not be adequate before pregnancy. Iron. Iron helps form some enzymes necessary for metabolism and is important in the formation of hemoglobin. The pregnant woman needs 27 milligrams of iron daily, an increase from 18 milligrams for a non-pregnant woman. The additional iron is needed for increased production of RBCs and for transfer to the fetus. Fetal stores of iron, which double during the last weeks of pregnancy, are important because the infant's intake of iron is low for the first 4 to 6 months after birth. Iron will be transferred to the fetus even if the mother is anemic, but infants will have less stored iron and an increased risk for anemia during the first year. Even though iron is better absorbed during pregnancy, it is probably the only nutrient that cannot be supplied completely and easily by the diet. Iron is present in many foods, but in small amounts. Table 8.5. The average woman's daily diet contains approximately 6 milligrams of iron for each 1,000 calories. In addition, some women restrict their intake of meats and grains in an effort to cut down on fat, carbohydrates, and calories. Menstrual bleeding causes loss of iron. Therefore, women frequently enter pregnancy with low iron stores. A Healthy People 2020 goal is to reduce iron deficiency in pregnant women to 14.5 from a baseline of 16.2%. Approximately 25% of iron from animal sources, called heme iron, is absorbed. Only approximately 5% of non-heme iron from plants and fortified foods is absorbed. Absorption of iron is affected by intake of other substances. Calcium and phosphorus in milk and tannin in tea and red wine decrease iron absorption if they are consumed during the same meal. Coffee binds iron, preventing it from being fully absorbed. Antacids, phytates in grains and vegetables, oxalic acid in spinach, and ethylene diamine tetraacetic acid, EDTA, a food additive, also decreases absorption. So I had to look that up. What contains EDTA? And crazy enough, from WebMD, in foods, EDTA bound to iron is used to fortify grain-based products such as breakfast cereals and cereal bars. EDTA is also used to help preserve food and to promote the color, texture, and flavor of food. So the very thing that they're using as an agent to fortify food with iron is decreasing absorption of iron, and of which is a non-heme source that you're only getting 5%. That's crazy. Sorry to go off on a tangent, a little commentary there, but I guess the takeaway from that is just eat meat. Foods cooked in iron pans contain more iron. Foods containing ascorbic acid and meat, fish, or poultry eaten with non-heme iron-containing foods increase absorption. Because of the difficulty of obtaining enough iron in the diet, healthcare providers often prescribe iron supplements of 30 milligrams per day. Women who are anemic, have more than one fetus, or begin supplementation late may need 60 to 100 milligrams daily. Supplementation may begin during the second trimester when the need increases and morning sickness has usually ended. Women who take high doses of iron also need zinc supplements because iron interferes with the absorption and use of this mineral. Iron taken between meals is absorbed more completely, but many women find it difficult to tolerate iron without some food. Iron taken at bedtime may be easier to tolerate. For best results, it should be taken with water or a source of vitamin C such as orange juice, but not with coffee, tea, or milk. Side effects occur more often with higher doses and include nausea, vomiting, heartburn, epigastric pain, constipation, diarrhea, and black stools. Women should be reminded to keep iron and all other medicines out of the reach of children. Accidental iron overdose is a significant cause of childhood poisoning. Calcium. Calcium is necessary for bone formation, maintenance of cell membrane permeability, coagulation, and neuromuscular function. It is transferred to the fetus, especially in the last trimester, and is important for mineralization of fetal bones and teeth. Calcium absorption and retention increase during pregnancy, and it is stored for use in the third trimester when fetal needs are highest. Although a small amount of calcium is removed from the mother's bones, it is insignificant and mineralization of the woman's bones is usually not affected. A common myth is that calcium is removed from teeth during pregnancy. In reality, calcium in teeth is stable and not affected by pregnancy. Dairy products are the best source of calcium. Whole, low-fat, and non-fat milk all contain the same amount of calcium and may be used interchangeably to increase or reduce calorie intake. Women with lactose intolerance, lactase deficiency resulting in gastrointestinal problems when dairy products are consumed, need other sources of calcium. Box 8.1. Let's take a look at that. Box 8.1. Calcium sources approximately equivalent to 1 cup of milk, 3/4 cup of yogurt, 1.5 ounces of hard cheese, 1.5 cups of low-fat cottage cheese, 1 cup calcium-fortified orange juice, 1 3/4 cup ice cream, 3 cup sherbet, 3.5 cup pinto beans, half block of tofu, 4.5 cup of broccoli, 1 cup cooked collard greens, frozen, 6 ounce canned salmon with bones, 3 ounce canned sardines with bones. Calcium is also present in legumes, nuts, dried fruits, broccoli, and dark green leafy vegetables. Although spinach and chard contain calcium, they also contain oxalates that decrease calcium availability, making them poor sources. Caffeine increases excretion of calcium. Large amounts of fiber interfere with calcium absorption. More calcium is needed by women younger than 18 years because their bone density is incomplete. The recommendations for calcium intake during pregnancy and lactation are the same as those for non-pregnant women. Women who do not eat dairy products because of lactose intolerance to avoid eating animal products or for other reasons should take supplements unless they can meet their needs with other calcium-rich foods. Calcium should be taken with vitamin D, which increases its absorption. It is better absorbed when taken with meals, separately from iron supplements. Sodium. Sodium needs are increased during pregnancy to provide for an expanded blood volume and the needs of the fetus. Although sodium is not restricted during pregnancy, excessive amounts should be avoided. Women are advised that a moderate intake of salt or the salting of foods to taste is acceptable, but intake of high sodium foods, box 8.2, should be limited. Let's take a look at that. Box 8.2, high sodium foods. Products containing the words salt, soda, or sodium, such as table salt, garlic salt, monosodium glutamate, bicarbonate of soda, baking soda. Salty tasting foods including sauerkraut and snack foods such as popcorn, potato chips, pretzels, crackers, condiments and relishes such as ketchup, chili sauce, horseradish, mustard, soy sauce, bouillon, pickles, green and black olives, smoked, dried, and processed foods such as ham, bacon, lunch meats, corned beef, canned soups, meats, and vegetables, unless the label states contents are low in sodium, canned tomato and vegetable juices, packaged mixes for sauces, gravies, cakes, and other baked foods. Nutritional Supplementation. Purpose. Food is the best source of nutrients. Healthcare providers usually prescribe prenatal vitamin and mineral supplements, and they are seen as an important part of pregnancy by many women. However, women with adequate diets may not need supplements except for iron and folic acid, which are often not obtained in adequate amounts through normal food intake. Expectant mothers who are vegetarians, are lactose intolerant, or have special problems in obtaining nutrients through diet alone may need supplements. Assessment of each woman's individualized needs determines whether supplementation is appropriate. Disadvantages and dangers. Because they believe supplements are a harmless way to improve their diets, some women take large amounts without consulting a healthcare provider. No standardization or regulation of the amounts of ingredients contained in supplements is available at this time. Label information for some supplements may not be accurate, and the supplement may not fulfill the health claims made for it. The use of supplements may increase the intake of some nutrients to doses much higher than recommended. Excessive amounts of some vitamins and minerals may be toxic to the fetus. Excessive levels of vitamin A can cause fetal anomalies of the bones, urinary tract, and central nervous system. High doses of some vitamins or minerals may interfere with the ability to use others. If women understand this, they are less likely to exceed recommended doses. Some women believe their nutrient needs can be met by vitamin mineral supplements and are likely concerned about their food intake. Supplements do not generally contain protein and calories and may lack many necessary nutrients. Nurses should emphasize that supplements are not food substitutes and do not contain all the nutrients needed during pregnancy. In fact, some nutrients important to pregnancy and provided by foods may be unknown at this time. Water. Water is important during pregnancy for the expanded blood volume and as part of the increased maternal and fetal tissues. Women should drink approximately 8 to 10 cups of fluids that are mostly water each day. Fluids low in nutrients, e.g. carbonated beverages, coffee, tea, or juice drinks with high amounts of sugar and little real juice, should be limited because they are filling and replace other more nutritional foods and drinks. My Plate. The USDA My Plate provides a guide for healthy eating for adults and children. Guidelines for pregnancy and lactation are discussed later and summarized in Table 8.6. Pregnant women can go to the website www.choosemyplate.gov to get an individualized diet plan specifically adapted for them and their needs during pregnancy. Whole grains. Breads, cereals, rice, and pastas provide complex carbohydrates, fiber, vitamins, and minerals. At least half of the daily serving should be whole grains because they provide more nutrients than processed grain products. Although foods can be enriched to replace some nutrients lost during processing, not all nutrients are restored by enrichment. My Plate recommendations are for 6 ounces each day for adult women. Pregnant women should have 7 to 9 ounces, and lactating women should have 9 ounces daily. Vegetables and fruits. Vegetables and fruits are important sources of vitamins, minerals, and fiber. The daily recommendation for vegetables for non-pregnant adult women is 2.5 cups, 3 to 3.5 cups for pregnancy, and 3 cups for lactation. Adult women should have 2 cups of fruit daily. Pregnant and lactating women should also have 2 cups of fruit daily. A wide range of vegetables and fruits provides the best nutrition. Dark green and orange or dark yellow vegetables are especially nutritious. Dairy group. The dairy group includes foods such as milk, yogurt, and cheese. They contain approximately the same nutrient values whether they are whole, 4% fat, low fat, 2% fat, or non-fat skim, 0% fat. But calories and fat are reduced in the latter two. The dairy group has especially good source of calcium. Adult women and those who are pregnant or lactating need 3 cups or the equivalent from this group. Protein group. Many adults think of meat, poultry, fish, and eggs as the only sources of protein. However, legumes, e.g. beans, peas, and lentils, nuts, and soybean products such as tofu are also good sources. Adult women should consume 5 to 5.5 ounces or the equivalent each day. Pregnant women need 6 to 6.5 ounces, and lactating women need 6 ounces of protein foods daily. A typical portion of meat, fish, and poultry varies in size. A 3-ounce portion is about the size of a deck of playing cards. Other elements. Concentrated sugars, fats, and oil should be eaten sparingly. They provide calories for energy but few other nutrients. An adequate allowance for oils for adult women is 5 to 6 teaspoons of unsaturated oils. Pregnant women need 6 to 8 teaspoons, and lactating women need 6 teaspoons of unsaturated fats daily. Foods containing saturated fats and trans fatty acids should be avoided. Food precautions. Although fish are an excellent source of nutrients, certain precautions should be taken. Large fish often have high levels of mercury, which can damage the fetal central nervous system. Pregnant and lactating women should avoid those fish. Other types of fish have smaller amounts of mercury and can be eaten weekly. Raw fish may contain parasites or bacteria and should be avoided. Some foods may be contaminated with Listeria monocytogenes, which causes listeriosis. If contracted during pregnancy, listeriosis may result in abortion, stillbirth, or severe illness of the newborn. More information about food safety during pregnancy can be obtained from the FDA website at fda.gov. Eggs can be contaminated with harmful bacteria and should not be eaten unless fully cooked. Only eggs pasteurized in the shell are safe to eat raw or partially cooked. Unpasteurized juices, cold deli salads, and raw sprouts should also be avoided. Eating raw or undercooked meat or unwashed fruits or vegetables may cause toxoplasmosis, with severe consequences to the fetus. Toxoplasmosis also can be contracted by contact with cat feces. Factors that influence nutrition. Age, knowledge about nutrition, exercise, and cultural background influence the food choices many women make and their nutritional status. The nurse should consider these factors when counseling women about their diets. Age. Age is an important consideration. The adolescent who is not fully mature needs nutritional support for her own growth. Older women who are in good health have the same nutritional requirements as younger pregnant women. They may have more knowledge about nutrition through life experiences or need as much teaching as younger women. Older women are more likely to be financially secure than very young women. Nutritional knowledge. Once pregnancy is confirmed, even women who have not previously been attentive to their diets often want to learn about the relationship between what they eat and the effect on the fetus. Although women know they should eat well during pregnancy, they may have little idea of what eating well means. Some lack basic understanding of nutrition, have misconceptions based on common food myths that interfere with good nutritional choices. They may seek information about nutrition from books, magazine articles, TV, and the internet. They benefit by receiving nutritional education from nurses. Exercise. Moderate exercise during pregnancy is encouraged. Women who exercise more strenuously or are athletes may need modifications of their diet to meet additional nutritional needs. Extra calories may be needed to restore the energy used during exercise. A serving of fruit, yogurt, or pasta before and after exercise may be sufficient. Additional fluids should be taken during and after exercise as well. Culture. Food is important in all cultures and often has special meaning during pregnancy and childbirth when certain foods may be favored or discouraged. Nurses need to know about the habits of a variety of cultures so they can provide culturally appropriate nutritional counseling. Before making assumptions about the influence of a woman's culture on her diet, the nurse should assess each woman individually. Not all women follow food practices considered typical for their cultures. The nurse should assess the woman's age, how long she has lived in North America, and whether she has adopted any common American eating habits. Greater exposure to the North American diet may cause younger members of a group to make more dietary changes compared with their older relatives. Some women, who usually follow an American diet, may return to some aspects of their traditional cultural diet during pregnancy to make sure they do not harm the fetus. Nurses often give women pamphlets in the appropriate language during nutritional teaching. Before giving a woman printed materials, the nurse should determine whether the woman prefers to read English or her native language. People who cannot read may not readily admit it to others. In addition, the reading level may be too complicated for a woman with little education. Having an interpreter discuss the material with a woman helps determine how well she can read and aids in other teaching. People of many cultures believe certain foods, conditions, and medicines are hot or cold and should be balanced to preserve health. Foods considered hot in one culture may not fit in that category in another culture, and the designation does not necessarily match temperature or spiciness of the food. In the Chinese culture, this belief is expressed with terms such as yin for cold and yang for hot, and may influence what the mother eats during pregnancy and the postpartum period. Food taboos may determine what some women eat during the childbearing period. For example, Samoan women avoid eating octopus or raw fish during pregnancy. Haitian women believe they should eat for two and eat a hearty diet with lots of red fruits and vegetables. They also believe eating white foods such as milk, white beans, and lobster after birth will increase the lochia. Some Asians believe vitamin preparations that contain iron harden the bones, making birth more difficult. Chinese women may avoid spicy foods such as chili peppers but eat birds' nests, considered a delicacy. Special foods may be customary during pregnancy or after birth. Punjabi women may drink milk to prevent melasma. A Korean family may bring the new mother a hot beef and seaweed soup to cleanse her body and increase breast milk production. Cultural preferences for foods are extremely varied. For example, some African Americans follow a diet similar to that of people living in the southeastern United States. Common foods include okra, collard greens, mustard greens, ham hocks, black-eyed peas, and hominy or grits. The diet of other African Americans, however, varies according to the geographic area in which they live. Lactose intolerance is common and results in a lack of calcium if other sources are not present in the diet. Intake of high sodium and fried foods may present health problems. Some Jewish women follow a strictly kosher diet. They avoid meat from animals without cloven hooves or do not chew their cud, which excludes pork and pork products. The meat must be processed to remove all blood and cannot be eaten in the same meal as milk. Muslim women also do not eat pork and may fast on certain days. Although the religion exempts pregnant and nursing women from obligatory fasting, the woman must make up the fasting days at another time. Some choose to fast regardless for spiritual reasons or so that they do not have to make up the days later. The diet of Native American women may contain blue cornbread, potatoes, wild greens, legumes, nuts, tomatoes, and squash. Lactose intolerance is common, and milk and cheese are avoided. Meats may include wild game and poultry. Fried dough, fry bread, is frequently served. Low-income Native Americans may receive food vouchers from the Special Supplemental Nutrition Program for Women, Infants, and Children, WIC. Food preferences for two cultures, Southeast Asian and Hispanic, are explored further here to show the influence of culture on diet. Immigrants from Southeast Asia are likely to follow diets similar to those in their homelands. Hispanics are a large minority group in the United States. Nurses throughout the United States need information about food preferences prevalent in these groups. Southeast Asian dietary practices. Southeast Asians include those from Cambodia, Laos, and Vietnam. Traditional cooking methods in these countries include searing fresh vegetables quickly with small portions of meat, poultry, or fish in a little oil over high heat. Meals cooked in this manner are low in fat and retain vitamins. Most meals are accompanied by rice, which increases the intake of complex carbohydrates, and soup. White rice is usually preferred over brown rice. A salty fish sauce called nuoc mam is also a part of most meals. Tofu and fresh fruits are frequent additions. Many Southeast Asians eat American foods along with their traditional diet. Such foods as eggs, beef, pork, and bread add nutrients but also fat to the diet. Candy, soft drinks, coffee, butter, or margarine, and fast foods have been less favorable influences because they are low in nutrients but high in sugar or fat. Effect of culture on diet during childbearing. In Southeast Asian cultures, pregnancy, especially the third trimester, is considered hot, and women eat cold foods to maintain a balance. The diet includes sour foods, fruits, noodles, spinach, and mung beans, and avoids fish, excessively salty or spicy foods, alcohol, and rice. Unfamiliar foods are avoided for fear they may harm the mother or her fetus. The postpartum period is considered cold, partly because of the loss of blood, which is hot. Mothers avoid losing more heat, which would negatively affect their health. They stay warm physically and choose to eat hot foods, including rice with fish sauce, broth, salty meats, fish, chicken, and eggs. They may refuse cold drinks but welcome hot fluids, requesting tea or plain hot water. The family frequently brings food to the mother while she is in the hospital, because hospital food may not meet her preferences. Increasing nutrients with traditional foods. Milk products are not part of the traditional Southeast Asian diet, and lactose intolerance is common. Soy milk may be used instead. Increasing the intake of commonly used dark green leafy vegetables such as mustard greens, bok choy, and broccoli increases calcium and iron. A broth made from pork or chicken bones soaked in vinegar, which removes calcium from the bones, is frequently served. If the mother avoids fortified milk, she may need vitamin D supplementation. Increasing the intake of meats and poultry elevates levels of protein, iron, vitamin B6, and zinc. Hispanic dietary practices. Spanish-speaking people such as Mexican Americans, Puerto Ricans, and Cuban Americans are often referred to as Hispanics or Latinos. Like Asians, many Hispanics follow the theories of hot and cold foods and conditions. They also consider pregnancy to be hot and the postpartum period to be cold, and adjust the diet accordingly. During pregnancy, Hispanic women may not take prenatal vitamins or iron because they are considered hot, or may take cold foods such as fruit juices to neutralize the effect. Dried beans, especially pinto beans, are a staple of Mexican-American diet and are part of most meals, served alone as refried beans or mixed with other foods such as rice. The major grain is corn, which is ground and made into a dough called masa to make corn tortillas. The corn is treated with lime and is a good source of calcium. Corn or flour tortillas are eaten with most meals. Rice is also an important grain. Many Hispanics are lactose intolerant, and milk is not commonly used. However, cheese is used in many dishes. Chili peppers and tomatoes are the most common vegetables. Green, leafy, and yellow vegetables are seldom included. Hispanic foods are often hot, spicy, and fried. The diet is high in fiber and complex carbohydrates. However, it also tends to be high in calories and fat, leading many Mexican Americans to become overweight. Puerto Rican and Cuban diets are similar to the Mexican American diet, with the addition of tropical fruits and vegetables from the homeland when available. Viandas, starchy fruits and vegetables such as plantains, green bananas, white and sweet potatoes, and chayote squash are common. They may be cooked with codfish and onion. Guava, papaya, mango, and eggplant are also used when available. Nutritional risk factors. The nurse should identify factors that may interfere with a woman's ability to meet the nutritional needs of pregnancy. Socioeconomic status. Poverty. Low-income women may have deficient diets because of lack of financial resources and nutritional education. Carbohydrate foods are often less expensive than meats, dairy products, fresh fruits, and vegetables. Therefore, the diet may be high in calories, but low in vitamins and minerals. A referral to the Temporary Assistance for Needy Families, TANF, or WIC, may be helpful if a woman's food intake is inadequate because of lack of money. Vitamin-mineral supplementation may be important, especially if her diet is likely to be inconsistent. Low-income families may experience food shortages at the end of the month when resources are depleted or when food is shared with a large number of people. Food supplement programs. The WIC program is administered by the USDA to provide nutritional assessment, counseling, and education to low-income women and children up to age 5 years who are at nutritional risk. The program also provides vouchers for foods such as milk, cheese, tofu, eggs, whole wheat bread, brown rice, tortillas, fruits and vegetables, iron-fortified cereal, juice, legumes, peanut butter, and formula to qualified women and their children. Eligibility is based on an income at or below 185% of the federal poverty level. Women are eligible throughout pregnancy and for 6 months after birth if formula feeding or 1 year if breastfeeding. Children at risk for poor nutrition may be eligible until 5 years of age. Further information is available at blah-blah-blah-blah-blah.wic. Vegetarianism. A vegetarian is a person who eats only or mostly plant food. It occurs in a variety of forms. Vegans avoid all animal products and may have most difficulty meeting their nutrient needs. Their diet may be lacking in adequate calcium, iron, zinc, riboflavin, and vitamins D, B6, and B12. Vegans should pay particular attention to obtaining these nutrients in food or supplement form. It is easier for lacto-vegetarians, those whose diet includes milk products, ovo-vegetarians, those who include eggs, and lacto-ovo-vegetarians, those who include milk products and eggs, to meet their nutrient needs. Although not true vegetarianism, a diet without red meats to decrease intake of saturated fats and cholesterol is a growing trend. Women who follow this type of diet usually eat small amounts of chicken, fish, and dairy products. Although the knowledgeable vegetarian may eat a very nutritious diet, she is at higher risk during pregnancy if she is new to vegetarian food practices, uninformed about pregnancy needs, or careless with her diet. She could fail to meet her nutrient needs. Meeting the nutritional requirements of the pregnant vegetarian. Energy. Vegetarian diets may be low in calories and fat, and some do not meet the energy needs of pregnancy. The diets are high in fiber and may cause a feeling of fullness before enough calories are eaten. A pregnant woman can increase caloric intake by eating snacks and higher calorie foods. If carbohydrate and fat intakes are too low, her body may use protein for energy, making it unavailable for other purposes. Protein. Although most vegetarians get enough protein, this area needs consideration, especially in vegan diets. Complete proteins contain all the essential amino acids the body cannot synthesize from other sources. Animal proteins are complete, but plant proteins, with the exception of soybeans, are incomplete proteins, lacking one or more of the essential amino acids. However, even a diet with only plant proteins can meet the needs of pregnancy. Combining incomplete plant proteins with other plant foods with complementary amino acids allow intake of all essential amino acids. Dishes with grains, e.g. wheat, rice, corn, and legumes, e.g. garbanzo, navy, kidney, or pinto beans, peas, and peanuts, are combinations that provide complete proteins. Complementary proteins do not have to be eaten at the same meal if they are consumed in a single day. Incomplete proteins also can be combined with small amounts of complete protein foods such as cheese or milk to provide all amino acids. Therefore, women who include even small amounts of animal products meet their protein needs more easily. Many vegetarians use tofu made from soybeans, which provides protein as well as calcium and iron. Meat analogs with a texture similar to meat but made from vegetable protein are available. Some look and taste like hamburgers, bacon, lunch meats, chicken patties, and other commonly eaten foods. Meat analogs may be fortified with nutrients that are often low in vegan diets. Calcium. Vegetarians who include milk products in their diet may meet the pregnancy needs for calcium. Vegans obtain calcium from dark green vegetables and legumes, but their high fiber diet may interfere with calcium absorption. Calcium-fortified juices or soy products such as soy milk or tofu may meet the requirements. Calcium supplements may be necessary. Vitamin D supplementation is especially important if the woman drinks no milk and has little exposure to sunlight. Soy milks may be enriched with vitamin D. Iron. Iron from plants in the vegetarian diet is poorly absorbed. Absorption is enhanced by eating a source of vitamin C in the same meal in which non-heme iron is consumed, or by preparing the food in iron pans. Iron supplements are particularly important for vegetarian women during pregnancy. Zinc. Because the best sources of zinc are meat and fish, vegetarians may be deficient in this mineral. Fortified cereals, nuts, and dried beans increase zinc intake. Vegans may need zinc supplements to meet their needs. Vitamin B12. Vitamin B12 is obtained only from animal products. Because vegetarian diets contain large amounts of folic acid, anemia from inadequate intake of vitamin B12 may not be apparent at first. Vegans may eat fortified food, such as cereal and soy products, or take B12 supplements. Vitamin A. Vitamin A is generally abundant in vegetarian diets. If a pregnant vegetarian takes a multiple vitamin mineral supplement, her intake of vitamin A may be excessive. Toxic effects include anorexia, irritability, hair loss, dry skin, and damage to the fetus. Supplementation should be individualized for each woman on the basis of her diet and needs. Lactose intolerance. Lactose intolerance is caused by a deficiency of the small intestine enzyme lactase, which is necessary for absorption of lactose, a milk sugar. Some degree of lactose intolerance is normal for most of the world's population after early childhood. This includes many African Americans, Hispanic, Asian, Pacific Islander, Native American, and Middle Eastern people. Although those with lactose intolerance may tolerate cultured and fermented milk products such as aged cheese, buttermilk, and some brands of yogurt, symptoms may occur after drinking as little as 1 cup of milk. Symptoms include nausea, bloating, flatulence, diarrhea, and intestinal cramping. Although the ability to tolerate lactose may increase during pregnancy, women who avoid dairy foods may not get the recommended amounts of calcium. Most women can tolerate small amounts, half a cup, of milk with meals, and they should increase their intake of other food sources of calcium. Soy milk, low lactose milk, and milk treated with lactase are available. The enzyme lactase can be purchased to be added to milk or taken as a tablet. Non-dairy sources of calcium should be increased. See box 8.1. Calcium supplements may be necessary for some lactose intolerant women. Nausea and vomiting of pregnancy. Morning sickness usually disappears soon after the first trimester, although some women experience nausea at other times of the day and for a longer time. Most women can consume enough food to maintain nutrition sufficiently. They are often able to manage frequent small meals better than 3 large meals. Protein and complex carbohydrates are often tolerated best, but fatty foods increase nausea. Drinking liquid between meals instead of with meals often helps. Eating a bedtime protein snack helps maintain glucose levels through the night. A carbohydrate food such as dry toast or crackers eaten before getting out of bed in the morning helps prevent nausea. Peppermint or ginger tea may relieve nausea in some women. Anemia. Anemia is a common concern during pregnancy. HGB values decrease during the 2nd trimester of pregnancy as a result of plasma increases, diluting the blood. This physiologic anemia is normal, see Chapter 6. During the 3rd trimester, hemoglobin levels generally rise to near pre-pregnant levels because of increased absorption of iron from the gastrointestinal tract, even though iron is transferred to the fetus primarily during this time. A woman may begin pregnancy with anemia or develop it during pregnancy. She is considered anemic if her hemoglobin is less than 11 grams per deciliter, or her hematocrit is less than 33% during the 1st and 3rd trimester. Her hemoglobin is less than 10.5 grams per deciliter, or her hematocrit is less than 32% in the 2nd trimester. If fetal iron stores during the 3rd trimester are sufficient, anemia will not develop in the newborn for the first 4 to 6 months after birth. However, if the woman's intake of iron is insufficient, her hemoglobin levels may not rise during the 3rd trimester. Iron deficiency anemia may develop, and transfer of iron to the fetus may be decreased. Anemic women need iron supplements and help choosing foods high in iron. See Table 8.5. Abnormal pre-pregnancy weight. In addition to teaching about dietary changes, the nurse should be alert for problems associated with abnormal pre-pregnancy weight. The woman who is below normal weight may not have enough money for food or may have an eating disorder. Obese women may have other health problems such as hypertension that may affect the nurse's nutritional counseling plan. Eating disorders. Eating disorders include anorexia nervosa, refusal to eat because of a distorted body image and feelings of obesity, and bulimia, overeating followed by induced vomiting, fasting, or use of laxatives or diuretics. These conditions can be a threat to pregnancy and fetal development and require close supervision during pregnancy. They are associated with miscarriage, low birth weight, preterm birth, congenital anomalies, and postpartum depression. Women with anorexia often have amenorrhea and have difficulty conceiving. Women with bulimia or subclinical anorexia are more likely to become pregnant. All women should be asked about eating disorders, and nurses should assess for behaviors of disordered eating. Some women with these disorders eat normally during pregnancy for the sake of the fetus. For others, the normal weight gain of pregnancy may be very stressful as old fears about obesity are reactivated. They may return to their previous eating patterns during pregnancy or in the early postpartum period when they do not lose weight immediately. Explaining that women often lose weight during breastfeeding may encourage them to breastfeed and eat a good diet during lactation. Women with eating disorders need a great deal of individual counseling to ensure they meet the increased nutrient needs of pregnancy and understand normal postpartum weight loss. Assessment of weight gain at each prenatal visit is especially important. Food cravings and aversions. Women may have a strong preference or a strong dislike for certain foods only during pregnancy. Cravings for pickles, ice cream, not necessarily together, pizza, chocolate, cake, candy, spicy foods, and dairy products are common. Food aversions include those to coffee, alcoholic beverages, highly seasoned or fried foods, and meat. The cause of cravings and aversions is not known, but they may be a result of changes in the sense of taste and smell. They are generally not harmful, and some, like aversions to alcohol, may be beneficial. Satisfying food cravings during pregnancy is thought important in many cultures. For example, women from India may believe cravings during pregnancy should be satisfied because they come from the fetus. Ethiopian women may believe that unfulfilled food cravings during pregnancy may cause miscarriage. Pica. Some women have cravings for non-nutritive substances. The practice of eating substances not usually considered part of a normal diet is called pica. Ice, clay or dirt, and laundry starch or cornstarch are the most common materials. But other items, such as chalk, baking soda, antacid tablets, coffee grounds, freezer frost, toothpaste, burnt matches, or ashes may be included. Pica is practiced by approximately 20% of pregnant women. It is more common in women from inner cities, rural areas, and the southeastern United States. African Americans, women who live in poverty and have poor nutrition, and those with a childhood or family history of the practice. However, pica is not limited to any one socioeconomic group or geographic area. Pica may be present before pregnancy occurs. The cause of pica is unknown, although cultural values may make pica a common practice. Pica may be related to beliefs regarding the effects of the substance on labor or the baby. Iron deficiency is often associated with pica, and the women should be tested to see if she needs additional iron supplementation. Clay and dirt are not sources of iron and may decrease the absorption of iron and other minerals. Substances eaten may be contaminated with parasites, other organisms, or toxins such as lead. Clay and dirt may cause constipation or intestinal blockage. Eating large amounts of ice may cause dental problems. Pica also may decrease the intake of foods and essential nutrients. Some women fear that their eating habits are harmful, but are unable to ignore the cravings. They often hide their eating practices from caregivers who might disapprove. Multiparity and multifetal pregnancy. The number and spacing of pregnancies and the presence of more than one fetus influence nutritional requirements. The women who have had previous pregnancies may begin a pregnancy with a nutritional deficit. In addition, she may be too busy meeting the needs of her family to be attentive to her own nutritional needs. Pregnancies, spaced at least 18 to 23 months apart, are healthier for the mother and the fetus. An interval of less than 6 months between pregnancies increases the risk for preterm and low birth weight infants, as well as maternal morbidity and mortality. Closely spaced pregnancies may not allow a woman to remedy any nutritional deficits originating during a previous pregnancy. If she has inadequate nutrient stores, she must meet nutritional needs from her daily diet and supplementation alone. Morning sickness from a new pregnancy soon after delivery may further interfere with an expectant mother's ability to eat an adequate diet. The woman with a multi-fetal pregnancy must provide enough nutrients to meet the needs of each fetus without depleting her own stores. She needs more calories to meet her weight gain and energy needs. A woman of normal pre-pregnancy weight should gain 17 to 25 kilograms, 37 to 54 pounds. If she is pregnant with twins, a gain of 5.5 to 9 kilograms, 12 to 19 pounds more than for women with a single fetus. When these women meet the recommended weight gain, they are less likely to deliver their twins before 32 weeks of gestation, and the infants are more likely to weigh more than 2,500 grams, 5.5 pounds. Women carrying triplets should gain a total of 23 to 27 kilograms, 50 to 60 pounds. Women pregnant with more than one fetus should consume an additional 300 calories per day for each fetus. Additional vitamin mineral supplementation may also be necessary. Substance abuse. Substance abuse often accompanies a lifestyle that is unlikely to promote healthy eating habits. The expense of supporting a substance abuse habit decreases money available to purchase food. Therefore, nutrition in pregnant women who abuse substances should be fully explored. Usually, more than one substance is involved, and the effects of various combinations of substances on nutrition are not fully understood. The damaging effects of smoking, alcohol, and illicit drug use on the fetus are discussed further in Chapter 11. Smoking. Cigarette smoking increases maternal metabolic rate and decreases appetite, which may result in a lower weight gain. As the amount of smoking increases, infant birth weight decreases in spite of an adequate diet. Smoking decreases the availability of some vitamins and minerals, and vitamin mineral supplements are important during pregnancy. Counseling to help the woman stop smoking, or at least decrease the number of cigarettes smoked during pregnancy, is essential. Caffeine. The evidence regarding the effect of caffeine on nutrition during pregnancy is conflicting, and more research is needed. At this time, it appears that caffeine intake less than 200 milligrams a day is not a major contributing cause of miscarriage or preterm birth. Until more is known about its effect on nutrition and the fetus, caffeine intake should be limited during pregnancy to less than 200 milligrams a day. An 8-ounce cup of brewed coffee contains approximately 137 milligrams. Brewed tea contains 48 milligrams per 8 ounces. Cola beverages contain 37 milligrams per 12 ounces, and cocoa mix contains 8 to 12 milligrams per packet, or 3 teaspoons. The nurse should discuss other sources of caffeine, including some over-the-counter medications. Alcohol. Because of the association between drinking and fetal alcohol spectrum disorders, women should avoid alcohol completely during pregnancy. Alcohol affects the absorption of vitamin B12, folic acid, and magnesium, and often takes the place of food in the diet. Vitamin mineral supplementation may be necessary for women who have had large intakes of alcohol before pregnancy, even if they stop drinking after conception, because their nutrient stores may be depleted. Drugs. The use of drugs other than those prescribed during pregnancy increase danger to the fetus and may interfere with nutrition. Even some prescribed drugs have risks during pregnancy that should be weighed against their benefits. The interaction of various drugs with nutrients is not fully understood. Marijuana increases appetite, but women may not satisfy their hunger with foods of good nutrient quality. Heroin alters metabolism and may cause a woman to become malnourished. Cocaine acts as an appetite suppressant, interfering with nutrient intake. Vasoconstriction from cocaine use decreases nutrient flow to the fetus. Cocaine users also tend to drink more caffeine and alcoholic beverages. Amphetamines and methamphetamines depress appetite. Women who use amphetamines for dieting should be warned that these drugs should be discontinued during pregnancy. Adolescence. Adolescent pregnancies are associated with a higher risk for complications for both the expectant mother and the fetus. Pregnant adolescents who are younger than 4 years, gynecologic age, number of years since menarche, and those who are undernourished at the time of conception have the greatest nutritional needs. Maternal growth may interfere with placental blood flow and transfer of nutrients to the fetus. As a result, the adolescent mother may add weight and fat to her own body rather than use it for support of the fetus. This leads to a tendency to have smaller infants, even with good weight gain in the mother. Nutrient needs. The DRIs for nutrients needed by pregnant adolescents are the same as those for older women for most nutrients. Adolescents need more calcium, phosphorus, magnesium, and zinc to meet their own growth needs. Individualized assessment of gynecologic age, nutritional status, and daily diet may indicate the need for increases in other areas as well. Common problems. The diets of teenagers before pregnancy are often low in vitamin A, folic acid, calcium, iron, and zinc. Although they may get 3 or 4 servings of vegetables daily, 1 or 2 may be potatoes and often are French fries. Girls average only 1.5 servings of fruits and dairy a day. Foods high in sugar and fat are common. These habits often lead to inadequate stores of nutrients for pregnancy. Supplements may be prescribed, but the adolescent may not take them regularly. This combination of poor intake and unreliable supplementation may further deplete nutrient stores and general nutritional status. Adolescents are often concerned about their body image. If weight is a major focus for a teenager and her peers, she is more likely to restrict calories to prevent weight gain during pregnancy. Teenagers tend to skip meals, especially breakfast. The fetus requires a steady supply of nutrients, and the expectant mother's stores may be used if intake is not sufficient to meet fetal needs. Teenagers are often in a hurry and want fast and convenient foods. Meals may be irregular and often eaten away from home. A significant part of the adolescent diet may consist of fast foods from restaurants or snack machines. These foods are often high in fat, sweeteners, and sodium, and low in vitamins, minerals, and fiber. Peer pressure is an important influence on nutritional status. Choosing fast foods that do not make her appear different from her peers, yet meet her added nutrient needs, is important for the pregnant adolescent. Teaching the adolescent about nutrition can be a challenge for nurses. It is essential to establish an accepting, relaxed atmosphere and show willingness to listen to the teenager's concerns. Her lifestyle, pattern of eating, and food likes and dislikes should be explored to determine whether changes are needed in her diet. The adolescent's home life may affect her nutritional status. She may live at home where the whole family may eat together. Or she may eat with the family only occasionally because she is often away at mealtimes. Some pregnant adolescents are homeless or in unstable situations. The number of other people in the home and the sufficiency of the food available also affect the dietary intake. The nurse should keep suggestions to a minimum and focus on only the most important changes. If an adolescent believes she must eliminate all her favorite foods, she is likely to rebel. Asking for the adolescent's input increases the likelihood she will follow suggestions. When changes are necessary, the nurse should explain why they are important for both the fetus and the expectant mother. A teenager, like other pregnant women, often makes changes for the sake of her unborn baby that she would not consider for herself alone. The teenager's likes and dislikes should be considered, and snacks should be included in the meal plan. The need to be like her peers is a major importance to the adolescents, especially when she is going through the changes of pregnancy. With education about appropriate choices, she can eat fast foods with her friends and still maintain a nourishing diet. Giving her plenty of examples of alternatives for which she can choose should be very helpful. Table 8.7 and Patient Teaching, Fast Foods and Nutrition. Other risk factors. Women who follow food fads may not meet the nutritional requirements for pregnancy. Those who have followed a severely restricted diet for a long time may have depleted nutrient stores. Nurses can help them understand the necessary changes to help ensure successful pregnancies. Women with complications of pregnancy such as diabetes, heart disease, and preeclampsia may need dietary alterations. Those with other medical conditions such as extreme obesity, history of bariatric surgery, cystic fibrosis, and celiac disease may need nutritional counseling from a dietitian. Women with phenylketonuria should follow a low phenylalanine diet before conception and during pregnancy to prevent cognitive impairment and other defects in the infant. This is true even if the woman has not usually followed the diet during adulthood. Nutrition after birth. Nutritional requirements after birth depend on whether the mother breastfeeds or formula feeds her infant. The nurse should review the woman's nutritional knowledge as she returns to her pre-pregnancy diet and teach the breastfeeding mother how to adapt her diet to meet the needs of lactation. Nutrition for the lactating mother. The lactating mother must nourish both herself and her baby as she did during pregnancy. Therefore, she continues to need a highly nutritious diet. Some DRIs, for lactation, are higher than those for non-pregnant adult women. Lactating women with poor diets may have reduced milk levels of fatty acids, selenium, iodine, vitamin A, and some B vitamins. Energy. During the first 6 months of lactation, the estimated energy requirement, EER, is 330 calories each day in addition to normal needs for women according to age, weight, and height. In addition to the calories consumed, approximately 170 calories per day are drawn from the woman's fat stores. This provides a total of 500 calories each day above pre-pregnancy requirements to meet the needs of lactation. The use of calories from fat stores aids in postpartum weight loss. The EER for the second 6 months of lactation is 400 calories more than pre-pregnancy needs. Although the infant takes solids after 6 months and decreases in milk intake, it is assumed that maternal energy stores have been used and the calories should come from the woman's daily intake. Milk volume is usually adequate even when a mother's diet is less than optimal. But volume may be reduced and maternal nutrient stores will be depleted with very low caloric intake. Protein. The DRI for protein during lactation is 71 grams each day. Although there is no change from the pregnancy DRI, it is important for the woman to maintain her protein intake throughout the breastfeeding period. Fats. The long-chain, polyunsaturated, omega-3 and omega-6 fatty acids are present in human milk. Therefore, they should be included in the mother's diet during lactation. Vitamins and minerals. The DRIs for lactating women are higher than for pregnancy for vitamins A, B6, B12, C, and E, and riboflavin, zinc, iodine, potassium, copper, and selenium. Lactating women who eat a well-balanced diet generally consume adequate amounts of essential nutrients to meet the infants and their own needs. Although the quality of the milk is not affected by the mother's intake of most minerals, the vitamin content may be decreased if her diet is consistently low in vitamins. Vitamin D is low in breast milk and supplements are recommended for infants. Milk levels of some nutrients, such as calcium, remain constant because some nutrients are drawn from the mother's stores if her intake is poor. Many health providers recommend women continue to take their prenatal vitamin mineral supplements during lactation. Specific nutritional concerns. Some women have difficulty consuming all required nutrients and need special counseling. This group includes women who are dieting, adolescents, vegans, women who avoid dairy products, and those whose diet is inadequate for other reasons. Dieting. Women who are concerned about losing weight after pregnancy need special consideration. After the initial losses in the first month, weight gradually decreases as maternal fat is used to meet a portion of the energy needs of lactation. However, breastfeeding does not necessarily result in weight loss, and some women maintain or even gain weight during lactation. This is more likely when weight gain during pregnancy was excessive. Dieting should be postponed for at least 3 weeks after birth to allow the woman to recover fully from childbirth and establish her milk supply if she is breastfeeding. Gradual weight loss is preferable and should be accomplished by a combination of moderate exercise and a diet high in nutrients with at least 1,800 calories per day. Weight loss of approximately 0.45 to 0.68 kilograms, 1 to 1.5 pounds a week is generally considered safe and will not compromise milk supply. Nursing mothers should avoid appetite suppressants, which may pass into the milk and harm the infant. They should not use liquid diet drinks or diets that severely restrict any nutrient because they will not meet the infant's need. Adolescence. The problems of the adolescent diet continue to be of concern during lactation. The adolescent may be deficient in the same nutrients as other mothers during lactation and may have a low iron intake. If she dislikes or cannot afford fruits and vegetables, her intake of vitamins A and C may be inadequate. Vegan diet. The milk of vegan mothers may contain inadequate amounts of vitamin B12, and they may need supplements. Vegans can meet their needs for other nutrients during lactation by diet alone with careful planning. Those who are not knowledgeable about nutrition should take supplements. Avoidance of dairy products. The recommendation for calcium is the same for pregnancy and lactation, and the calcium content of breast milk is not affected by maternal intake. Less calcium is excreted in urine during lactation. Although calcium is removed from the mother's bones during lactation, it is replaced when she is no longer breastfeeding. Women who do not eat dairy products should obtain calcium from other sources or take a calcium supplement. Unless they consume foods fortified with vitamin D or are exposed to sunlight, they may require vitamin D supplementation, which is necessary for calcium absorption. Inadequate diet. Women with cultural or other food prohibitions may need help choosing a diet adequate for lactation. Low-income women may need referral to agencies such as WIC. If the mother must take medications that interfere with absorption of certain nutrients, her diet should be high in foods containing those nutrients. Alcohol. Although the relaxing effect of alcohol was once thought to be helpful to the nursing mother, the deleterious effects of alcohol are too important to consider this suggestion appropriate today. Alcohol may interfere with the milk ejection reflex and may be harmful to the infant. Alcohol level in the milk peaks at 30 to 60 minutes after drinking if it is taken alone and 60 to 90 minutes if taken with food. When mothers drink alcohol, they should not breastfeed for at least 2 hours. Caffeine. Foods high in caffeine should be limited. Infants of mothers who drink more than 2 to 3 cups of caffeinated coffee or the equivalent each day may be irritable or have trouble sleeping. Fluids. Nursing mothers should drink fluids sufficient to relieve thirst, which often increases in the early breastfeeding period. 8 to 10 cups of non-caffeinated fluids is adequate. Drinking large quantities of fluids, as was once recommended, is not necessary. Nutrition for the non-lactating mother. The postpartum woman who is not breastfeeding can return to her pre-pregnancy diet, provided it meets recommendations for adult women. Her diet should contain enough protein and vitamin C to promote healing. Many healthcare providers suggest that the woman continue to take her prenatal vitamin mineral supplements until her supply is finished. This ensures adequate intake during the time of involution and helps renew nutrient stores. The nurse should assess the mother's understanding of the amount of food she needs from each food group. A review of important nutrient sources for calcium and iron may be relevant. If the woman was anemic during pregnancy, she should continue to take an iron supplement until her hemoglobin level returns to normal. Weight loss. When her baby is born, a woman can expect to lose about 4.5 to 5.8 kilograms, 10 to 13 pounds, immediately. She loses approximately another 3.2 to 5 kilograms, 7 to 11 pounds, during the first week. Weight loss continues with the greatest loss during the first 3 months. If her weight gain during pregnancy has not been excessive, she will probably lose all but 1 kilogram, 2.2 pounds, within a year if she follows a well-balanced diet. She should decrease her caloric intake to her normal not pregnant levels to avoid retaining weight. Suggestions for sensible calorie reduction combined with exercise are appropriate. Women who gain excess weight during pregnancy may have difficulty losing it after birth and may need help from a dietitian to plan a weight loss program. Those who did not lose the weight gained during pregnancy may begin the next pregnancy overweight, and this may lead to further retention of weight after birth. Mothers are sometimes so involved with the needs of the infant that they fail to eat properly. They may snack instead of planning meals for themselves, especially if they are home alone with baby during early weeks. The nurse should remind them that snacking often involves high caloric intake without meeting nutritional needs. During the postpartum period, the mother needs to ensure her own good health so that she is able to care for her baby. Therefore, meals and snacks should be high in nutrient content. Application of the nursing process. Nutrition for childbearing. The nursing process focuses on determining any factors that might interfere with a woman's ability to meet the nutrient needs of pregnancy, the postpartum period, and lactation, and finding solutions to any problems identified. This process primarily involves education of the woman. Assessment. Interview. The interview provides an opportunity to develop rapport and identify any specific problems affecting dietary intake. Appetite. Begin the interview by discussing the woman's appetite. Has it changed during the pregnancy? How does it compare with her appetite before pregnancy? Morning sickness may decrease food intake during the first trimester. Determine the severity and duration of nausea and vomiting. Hyperemesis gravidarum is the most serious form of this problem and may require intravenous correction of fluid and electrolyte imbalance and parenteral nutrition. See Chapter 10. Eating habits. Assess the usual pattern of meals to discover poor food habits such as skipping breakfast, eating only snack foods for lunch, or eating fast foods for most meals. Determine who cooks for the family. If someone else does the cooking, discuss nutritional needs during pregnancy with that person. If the woman does the cooking herself, the likes and dislikes of other family members may influence what she serves, especially if she has little understanding of her own needs during pregnancy. Food preferences. Ask the woman about her food preferences and dislikes. Some women experience aversions to certain foods, such as meats, only during pregnancy. Careful counseling helps work around dislikes and aversions to find ways of obtaining the nutrients needed. For example, if she dislikes most vegetables, fruits may often be substituted. Discussing likes and dislikes provides an opening to ask about food cravings and pica. Cravings may be for nutritional foods or foods low in nutrient density or eaten in amounts that interfere with the intake of other foods. Ask about pica in a matter-of-fact manner to avoid giving an impression of disapproval. Food items such as ice are included in pica, and the nurse should ask about it as well. Also determine whether the mother eats large amounts of a particular food or group of foods. When assessing for pica, the nurse might say, "Have you had any cravings for special things to eat during your pregnancy?" This can be followed with, "Women sometimes eat things like ice, clay, dirt, and laundry starch during pregnancy. Have you tried these?" Potential problems. Identify any obvious areas of potential deficiency. For example, the woman might eat little meat, avoid vegetables, be lactose intolerant, or follow a fad diet. Assess the woman's knowledge about nutritional needs during pregnancy. Inquire how long the vegetarian has followed her diet, determine which foods she includes, and question her awareness of changes necessary during pregnancy. Psychosocial influences. Psychosocial factors should be assessed because they can affect dietary intake. Women who are fatigued, stressed, and anxious during pregnancy may consume more high-calorie foods but have lower intake of some important nutrients. The diets of postpartum women are often affected by psychosocial factors. Those with stress, weight-related concerns, negative body image, and depressive symptoms are less likely to eat healthful diets. Identify cultural or religious considerations that affect the diet. Do these apply only during pregnancy or at all times? Assess whether the woman follows all or only certain restrictions, and determine the effect on her nutrient intake. Identify other factors that affect nutrition. Women with low incomes may not know about sources of assistance. A woman's smoking habits, alcohol intake, and other substance abuse may become obvious during the interview. Determine whether she takes medications that interfere with nutrient absorption. Other questions include the amount of time she has for food preparation and the frequency of fast food intake. Provide an opportunity for the woman to ask about special concerns regarding her diet. This may bring out fears about weight gain, worry that specific foods could hurt the fetus, or other issues that have not yet been addressed. Diet history. Diet histories provide information about a woman's usual intake of nutrients. Food intake records, 24-hour diet histories, and food frequency questionnaires can form a basis for counseling about any changes required to meet pregnancy needs. They also help the woman become more aware of her eating habits. Food intake records. Food intake records are used to report foods eaten over 1 or more days. Instruct the woman to list everything she eats throughout the day. The list is more accurate if she writes down each food immediately after eating. Some women eat more nutritious foods during the recording period when they are concentrating on good diet and then return to a less wholesome diet later. 24-hour diet history. Ask the woman to recall what she ate at each meal and snack during the previous 24 hours. Use specific questions about the size of portions, ingredients, and food preparation for each meal. Models of food items and measuring utensils may be helpful to determine portion sizes. Inquire about beverages and snacks between meals and at bedtime. Ask if this sample is typical of her usual daily food intake. If it is not, ask what foods are more representative of her usual intake. Analyze her diet to determine whether the woman has met the recommendations for specific food groups, calories, and protein. Detailed analysis for individual nutrients is unnecessary because it is time-consuming and because daily variation in intake occurs. The food history may be inaccurate if the woman cannot remember what she ate or if she is mistaken about amounts of food. The expectant mother may alter her reported intake to make it appear she is eating better. She may be embarrassed about her inability to follow the diet prescribed because of lack of money or cooking facilities. The atmosphere created by the nurse is important in helping mothers feel free to be honest. Food frequency questionnaires. Food frequency questionnaires, which contain lists of common foods, may provide information about diet over a longer period. Review the questionnaire with the woman and ask how often she eats each food. Foods consumed daily and weekly are her most common source of nutrients. Analyze the list to determine whether foods from each group are eaten in adequate amounts to meet pregnancy needs and determine whether any major groups are omitted. Physical assessment. Information about nutritional status can be obtained during the physical assessment. This assessment includes measurement of weight and examination for signs of nutritional deficiency. Weight and height at initial visit. Weigh the woman at the first prenatal visit to provide a baseline value for future comparison. Ask if she has gained or lost weight. Measure her height without shoes because she may not have had a recent accurate measurement. Determine her BMI from her pre-pregnancy weight and height to draw conclusions about her nutritional condition. If her weight is low for height, nutritional reserves are marginal. Weight at subsequent visits. Assessment of weight gain at each prenatal visit provides an easy method of estimating whether nutrition is adequate and serves as a basis for counseling. Weigh the woman at each visit on the same scale with approximately the same amount of clothing. Record the weight on a weight grid at each visit throughout the pregnancy. The grid allows examination of the pattern of weight gain as well as the total gain to date. It also helps keep track of the amount of gain between individual visits. Be careful not to overemphasize weight gain. In some instances, a woman may be afraid caregivers will be disapproving if she gains weight and consistently may diet or fast a day or two before her prenatal visits. Signs of nutrient deficiency. Observe for indications of nutritional status or any signs of deficiency. For example, bleeding gums may indicate inadequate intake of vitamin C. Actual deficiency states, however, are not likely to occur in women in most industrialized countries. The exception is iron deficiency anemia, which is common in a mild form. Signs and symptoms include pallor, low hemoglobin level, fatigue, and increased susceptibility to infection. Laboratory tests. Laboratory tests for in-depth analysis of nutrient intake are generally impractical. Analysis of specific nutrients is expensive, and normal laboratory values during pregnancy have not been determined for all laboratory tests. HbG, HCT, and in some cases, serum ferritin tests are most often used to determine anemia. Ongoing nutritional status. At each prenatal visit, 1. Reassess the woman's dietary status. 2. Ask if she has any questions about her diet or has had any difficulty 3. Check her weight gain to see whether she is within the expected pattern. 4. Evaluate her HbG and HCC levels to detect anemia if appropriate. And 5. Explain what assessments are being made and why. Identification of patient problems. Although some women consume more calories than necessary during pregnancy and risk obesity as a result, other women are likely to eat fewer nutrients than recommended. The problem may be related to many factors, the most common of which is general lack of knowledge of nutrition. Analysis of the data collected enables the nurse to identify actual and potential patient problems and develop an individualized plan of care. Planning. Expected outcomes. The expected outcomes for an actual or potential nutritional problem in pregnancy include the following. The woman's daily diet will include the recommended amount of food for each food group for pregnancy. The woman with a normal BMI before pregnancy will gain approximately 0.5 to 2 kilograms, 1.1 to 4.4 pounds, during the first trimester, and 0.35 to 0.5 kilograms, 0.8 to 1 pound per week during the second and third trimesters for a total gain of 11.5 to 16 kilograms, 25 to 35 pounds. Interventions. Identifying problems. After analyzing food likes and dislikes and taking a 24-hour diet history, identify any obvious areas that are lacking and determine the woman's knowledge about the nutrient needs of pregnancy. If the woman is experiencing pica, try to find foods to replace the substances she is eating. Crunchy foods may replace some ice ingestion. Other women are willing to make substitutions, such as non-fat dry milk powder for laundry starch. Explaining nutrient needs. Use the woman's diet history as a basis to introduce information about nutrition during pregnancy. Explain the recommended servings from each food group. Help her analyze her own diet so she understands the process, and determine whether she meets the number of servings recommended for each food group. Explain which important nutrients are provided in each food group and why they are necessary for her and the fetus. Calculate a rough estimate of calories, protein, iron, folic acid, and calcium in the diet to help her identify whether she eats enough of these foods on a regular basis. Compare the usual sources of these nutrients with her diet history and favorite foods. Suggest ways she can increase nutrients that are lacking by increasing foods that are good sources. Advise a woman that adequate nutrition, especially intake of iron and folic acid, may help reduce fatigue during pregnancy and after birth. Providing reinforcement. Give frequent positive reinforcement when the woman is eating appropriately. Assist her in evaluating weaknesses in her diet and planning ways to remedy them. Figure 8.3. Ask her what problems she foresees in obtaining the nutrients she needs. Explore a variety of options to overcome expected problems, and ask about how these changes will affect the rest of her family. Perhaps the changes she needs to make for her own needs would be beneficial to the entire family. If the woman can read, give her printed materials in her preferred language on nutrition during pregnancy and review them with her. If she can take the information home, she can review it to ensure she is eating properly. A small pamphlet with pictures might be placed on the refrigerator to help her remember what foods she needs each day. Demonstrate portion sizes by showing her plastic models of frequently eaten foods. These are available for various ethnic foods as well, and help women understand how to incorporate cultural foods into the pregnancy food plan. Evaluating weight gain. Compare the woman's weight with a weight gain chart to ascertain whether she has gained the appropriate amount of weight for this point in her pregnancy. Discuss the importance and expected pattern of weight gain and explain the need to eat foods high in nutrient density when she is increasing calories. If she is greatly outside of normal ranges, discuss necessary diet modifications with her primary healthcare provider. For example, an obese woman is expected to gain some weight, but the amount should be individualized according to her particular needs. Although slight variations from the recommended weight gain have little significance, possible reasons for larger differences should be examined carefully. For women of normal weight, a monthly gain of less than 1 kilogram, 2.2 pounds, should lead to a discussion of diet and possible problems in food intake. A gain of more than 2.9 kilograms, 6.5 pounds, per month may signify edema. However, errors in calculation of gestation may reflect a pattern of weight gain different from that expected. Encouraging supplement intake. If vitamin mineral supplements have been prescribed, determine whether she takes them regularly, and if not, explore reasons and possible solutions. Iron supplements often cause constipation, but dietary changes such as increased intake of fluids and fibers can help prevent this problem. Box 8.3. If she forgets, suggest she take vitamin mineral supplements with meals or iron tablets with orange juice at bedtime just before brushing her teeth. If she avoids iron supplements because of side effects such as nausea, she can take them with meals or snacks. Even though taking iron supplements with food decreases the absorption of the iron, it is preferred to not use the supplements at all. Let her know that black stools are a harmless side effect of iron supplements. Making referrals. The nurse can provide adequate nutritional counseling for most women, but some situations warrant referrals to other sources. Refer women with health problems that affect nutrition, such as diabetes, celiac disease, extreme weight problems, to a dietitian with follow-up by the nurse. Women with inadequate financial resources to buy food can be referred to public assistance programs such as WIC. At the next visit, determine whether the woman obtained the help needed and whether other assistance is necessary. Evaluation. Ongoing evaluation of diet and pattern of weight gain throughout the pregnancy determines whether the goals have been met. The woman should eat the recommended amount of foods from each food group daily. She should gain approximately 0.5 to 2 kilograms, 1.1 to 4.4 pounds during the first trimester, and 0.35 to 0.5 kilograms, 0.8 to 1 pound per week during the rest of her pregnancy. Total weight gain should be about 11.5 to 16 kilograms, 25 to 35 pounds.